Fantastic. Lovely to be with you, Leseko, and colleagues on the front line. I work at the NICD, and we do the diagnostics for the National Fever Rash Surveillance Program. And so we receive queries ranging from the contents of the vaccines for people who are allergic through to diagnostic dilemmas or SSPE. But mainly we don't see patients. So hats off to you guys, because you are the ones who give us the samples, the specimens, and most importantly, you're the ones who keep the country safe. So I'm going to share my screen and I'm going to check that everyone can see it. Is that visible?
Thank you. We can see your screen. Thanks.
So I'm going to go through some basic virology, and then we're going to talk in cases. We're going to talk about a case of fever rash, where we're going to be thinking with the clinician's hat around diagnostics and management. We're then going to, I'm going to share a second case, and we're going to be thinking with the infection prevention and control practitioner in terms of quarantine and isolation. And then I'm going to share with you the story of an outbreak in 2017. And we're going to think there with a public health practitioner. And I'm going to close with some background on the global context of measles prevention, elimination, eradication. And I'll end off with some statistics from South Africa that set the scene for our current outbreak. And then Chinoa will give us an update on the current outbreak statistics and where we're at. And then we'll be able to open for some questions. So measles virus is a negative stranded pleomorphic RNA virus. It's short, it's only 15,000 nucleotides, and it codes for 6 structural proteins and 2 non-structural proteins. And it has 8 clades, they're named A to H, and 23 recognized genotypes. But the main thing is that unlike many other viruses, it's genetically stable with very little variation from generation to generation and almost no variation over time, such that the vaccine that was developed in the 1960s is still highly potent and effective today, nearly 60 years later. This, of course, is unlike the SARS-CoV-2 virus and the influenza viruses that we're familiar with that are subject to antigenic shift and antigenic drift. How does the measles virus enter and cause disease? Essentially, the hemagglutinin molecule on the surface of the measles virus attaches to 3 specific human proteins. The first is CD46, and the second is CD147. These are molecules that are distributed widely in human tissues, but particularly on the respiratory tract epithelial cells. However, once it has invaded, it then attaches and moves from cell to cell using a receptor called CD150. And this allows for the rapid dissemination through tissues in the body once it's entered. So if you see the figure on the right, you'll see as the virus replicates, and that's indicated by the height of the black line, it starts in the respiratory epithelium, but then it expands exponentially and it finds its way to all organs in the body, including the skin. This is the period of primary viremia, followed by then a secondary viremia when it moves from the local lymph nodes through the blood into all the tissues. The incubation period following infection is around 9 to 14 days. And very importantly, a person is infectious 4 days before the onset of the rash until 2 days after. So you can see in the middle graph of the clinical symptoms, the blue period is the incubation period, and that's usually 9 to 14 days or on average, and any period between there. And the infectious period is measured 4 days before and 4 days after the onset of rash. Now, of course, the challenge from a clinical point of view is that one doesn't know where the rash, when the rash is going to appear, and so one doesn't know how to count -4, -3, -2, and to understand that the virus and the patient is infectious at this time point. And so often it's only when the rash appears that the person and clinician knows that or suspects measles, by which time, of course, the person has transmitted measles to all the contacts. Interestingly, the presence of the rash signals the formation of neutralizing antibodies. And usually the day of the rash and the day after the rash are the height of the clinical symptoms. The person will feel worse during this time, but as soon as the rash appears, the person generally starts to feel better. So let's go on to some cases. This is a case of a 14-month-old infant who presented on the 24th of November, 2021, to the emergency department of a district hospital in the Western Cape. The family, within the last 28 days, had recently arrived from the DRC. The child had developed a fever, a conjunctivitis, and a cough. And on the day of presentation to the hospital, the mom noticed this rash, which you see here. And so she took her child to the hospital. So the clinicians rightly noted what we would call a macular-papular rash. That's a flat rash that is not vesicular in nature. And some specimens, including blood and urine, were submitted to the NICD for testing. So how does measles begin clinically? Classically, it begins with a non-specific prodromal illness with malaise, fever, and a progressive development of cough and runny nose or coryza, loss of appetite and fever, and sometimes conjunctivitis. The rash usually starts on the face and upper arms and neck and progresses to the extremities and will include a rash on the palms and soles. It heals with desquamation. So as the rash starts to heal, the skin will develop a fluffy white texture as the infected skin cells de-slough off. And as I said, the worst symptoms occur on day 1 to 2 of the rash. So measles is usually an uncomplicated infection in children, healthy, otherwise well children. However, there are a number of conditions that exacerbate underlying measles and have a predisposition or lead to a predisposition to complications. These complications include diarrhea, which can lead to dehydration, pneumonia, which is often clinically inapparent, but when it's present, it may be severe. Otitis media is a common complication in younger infants. And then really, 1 in 1,000 children may develop encephalitis, which will present with a headache, sometimes an altered level of consciousness and seizures. Measles is very unusually complicated by death. However, in children who have, or adults who have a predisposition to severe measles, mortality rates can be as high as 20% in specific cohorts. And these persons who have a predisposition to severe measles are children or infants under the age of 1 year of age, infants of any age who are malnourished, infants with or children with advanced untreated HIV, and then anybody with deficits in cell-mediated immunity. This includes adults on cancer chemotherapy and adults with advanced untreated HIV infection. So here are some examples of measles rash from a lovely article, the reference of which is down below. And classically, you'll often read in the textbooks about Koplik spots, which are erythematous spots on the inner cheek, the buccal cavity. And these Koplik spots are supposedly pathognomonic for measles. In other words, you don't see them in other conditions. And if you see Koplik spots, you can say this is a case of measles. In our experience at the NICD, when we've consulted with clinicians who swear they see Koplik spots, it does often happen that we do not make a diagnosis of measles, we diagnose something else. So it's my opinion that Coptic spots are not really helpful to confirm the diagnosis of measles. However, if one sees something like Coptic spots, it is helpful to do measles diagnostic tests in the presence of someone meeting the case definition, and that is fever plus rash plus one of the three. The problem with measles clinical management is that the differential diagnosis is very broad. And so one cannot make a diagnosis of measles clinically, except under certain circumstances. So the differential diagnosis could include rubella, it could include scarlet fever, it could include a clinical condition called exanthum subitum, which is caused by human herpes virus 8. Human herpes virus 7 can sometimes, human herpes virus 6. Human herpes virus 7 can sometimes cause a clinical syndrome like exanthum subitum. Children who are severely ill or prostrate may have a particular rash that could be confused with measles, and these children may also have mesococcemia. Sometimes parvovirus B19 and cytomegalovirus can also cause a maculopapular exanthum. And so, for this reason, if a clinician suspects a case of measles, in other words, if you see a case of a maculopapular rash plus fever plus one of the QCs, it is essential from a surveillance perspective to submit a sample for laboratory confirmation. Measles does not look like Mpox. Mpox is a vesicular rash that looks very similar to chickenpox. It usually starts as a pustule that is elevated, and then at some point the pustule may rupture or the vesicle may rupture and then lead to a crusting over, which may sometimes be followed by a secondary infection. The classic population that is affected by Mpox are adults, usually sexually active and more often male than female. And so Mpox is unlikely in children and looks very different to measles. The next problem that clinicians face is around taking diagnostic tests. Now, the laboratory and the NICD in particular can conduct two kinds of tests for measles. The first is a serological assay where we look for antibodies, and the second is PCR where we directly detect measles RNA in the sample. Now, the interpretation of both tests depends on the type of sample and the type of test that is done, and the timing of collection of the sample relative to rash onset. So the figure on the right, on the x-axis, the horizontal axis, shows the number of days before or after the onset of rash. So the rash starts at day 0, and you can see the x-axis starts at -3, -1, and then goes 1, 3, 5, 7, 14, etc. The vertical axis shows the percentage of patients that are positive for a particular test or a particular marker. The purple line that does an exponential curve and then declines slowly after that by day 90 is IgM, immunoglobulin class M, that is found in serum or dried blood spot or oropharyngeal swab. The dotted blue line is IgG, that may be found in the same sample. The black line that starts off high and that starts at the intersection of the green vertical line is virus detection. And one may detect virus in an oropharyngeal swab, which is the black line, or in a dried blood spot or serum tube in the dotted line, or in blood where virus culture may be detected from. And what you'll notice is that at point 0 on the day of onset of the rash, which is the green line, the virus, the proportion of patients who have a positive PCR test, in other words, virus detection in OF, which stands for oropharyngeal swab, will be very high. It will be almost 100%. But the proportion of patients who have a positive IgM in serum will be very low on the day of presentation of the rash. And so it stands to reason that if you want to get the best diagnostic result from measles testing, you need to understand where the patient is relative to the onset of the rash. Now, this kind of information you get from the patient and the caregiver by asking, when did the rash appear? And if the rash appeared 2 to 3 days later, 2 to 3 days ago in the past, you can look at the red line and see that about 75% of patients at this point will have a positive IgM. That will be the point where the red dotted line, vertical red line, intersects with the purple line that represents IgM. But at that point, a lower proportion of patients will be positive by PCR on blood, and a lower, and this graph is not particularly accurate, the virus detection in the oropharyngeal swab falls off very rapidly after the onset of the rash, but is slower to fall off, or in other words, to become lower than blood. So if you take a blood specimen and you test it for PCR on day 3 after rash, we are in the laboratory quite unlikely to have a positive PCR, but very likely to have a positive IgM test. You'll also appreciate that it may be possible that someone with measles has a negative PCR test and a negative IgM assay. And in this case, we would like to repeat testing 2 or 3 days later so as to maximize our chance of identifying a positive measles patient. The practice of the NICD is that if in the case of someone who meets the case definition, has a fever and a rash, and they have what we call an equivocal IgM result, in other words, the result is positive but not at a sufficiently high threshold, we request the laboratories, the clinicians, to send a repeat sample a few days later. So, what happened to our patient? Well, the patient's blood results returned 4 days later. We were very lucky. This patient landed up being IgM positive, but we also successfully managed to detect PCR, measles RNA in the urine. Urine is a useful sample to send because it is easy to obtain, and it tends to be to contain excreted virus particles for a little bit longer than blood, and just as long as a throat swab. It's easy to collect as well, relatively easy. When we sequenced this patient's measles virus, we found that it was the B3 genome or lineage, and it was identical to the strains that are currently circulating in the DRC and in Zambia. And their travel history, of course, suggested that the infection had been acquired there. So let's move on to the next case. Oh, no, wait, we can't do that yet. We have to talk about treatment. So what would you do for a stable child who presents with a fever and a rash? The first most important is symptomatic treatment, to firstly treat the fever and to manage dehydration or hydration to prevent the onset of dehydration. Very importantly, vitamin A has been shown to prevent complications, particularly keratoconjunctivitis, which may lead to corneal scarring. And it is the guidelines for the administration of vitamin A are shown in the slide, and these are taken from the essential drug list that is publicly available on the web. If the child has a cough and elevated respiratory rate, one would treat secondary infection with antibiotics for routine community-acquired pneumonia. But if there is no evidence of respiratory infection, one would not use prophylactic antibiotics. Who should you be cautious with? Who should you refer? Adults generally have a worse subjective course of measles and are at risk for the development of pneumonia, although not all adults. And children under the age of 6 months, and I would say children under the age of a year, one should watch. These children often have severe diarrhea and pneumonia, and it's probably helpful to keep these children in hospital until they show signs of clinical improvement. Any person who's immunocompromised or has TB co-infection should be admitted for observation and supportive care. And where complications are present, including respiratory distress, pneumonia, dehydration, and very importantly, neurological complications, these children should be admitted for observation or referred. If we move on to the second case, a 17-year-old female was admitted to a private hospital on the 13th of April for chemotherapy. She commenced with a rash on the 14th of April, and by the 5th of May, deteriorated with a pneumonitis. A very astute microbiologist suggested a diagnostic test for measles. This young girl never had a rash. Oh, sorry, her rash was on the 14th of April, but it was atypical. And sadly, this patient died on the 24th of May. In the meantime, her father was diagnosed with measles on the 14th of May, and there were no known contacts. However, on the 17th of May, a male patient who shared a ward with a 17-year-old female was diagnosed with measles. He developed a rash and he died on the 22nd of June. The hospital isolated the patient and implemented airborne and droplet precautions, screened staff vaccination records, and offered staff booster measles vaccination. What was not reported was that an oncologist who wasn't the patient's doctor, this oncologist had seen patients in the ward where the patient was, but didn't see the patient directly, had been ill and off work, and his wife had been diagnosed with pneumonitis. And he had become ill after returning from Eastern Europe. And interestingly enough, when our laboratory did the genotyping of the measles strain, we found that it was an Eastern European measles strain. And it was, in fact, an identical sequence to an airport worker in Munich. And we later discovered that this doctor had flown through Munich on his return from Europe. So this is a tragic case of nosocomially acquired measles in immunocompromised persons with impaired cell-mediated immunity. So it is helpful for us to think through what are the risk factors in the hospital setting regarding post-exposure prophylaxis. The important thing is that hospitals are likely to see more cases of measles than, particularly in the emergency department, than those who are in the clinical environment, in the community environment. And of course, because measles have such a high effective reproductive number, anybody who's not vaccinated will be at risk, even those who are not directly in contact. There is a small proportion of people in adulthood who experience waning immunity, and therefore it does make sense to offer healthcare workers a measles booster, particularly during outbreak context. This is something that can be arranged with the hospital infection control focal point. So very importantly, if a case of measles is identified in hospital, it would be a review vaccination records of staff and understand who was in the emergency department. The measles vaccine may be given successfully to abort infection or ameliorate the clinical symptoms within 3 to 6 days of exposure to unvaccinated persons. And infants under the age of 6 months should be vaccinated for measles, but then they should still receive their usual EPI vaccines. And the reason for this is infants under 6 months of age are often, they still have maternal antibodies and they are not vaccinated routinely because of the interference between maternal antibodies and vaccination. However, in this particular context, so for example, a child under the age of 6 months, is exposed to a measles case, it would make sense to vaccinate them, to offer them the best possible protection. If someone may not receive a live attenuated vaccine, and this includes persons who have cell-mediated immunity, persons with advanced untreated HIV infection, oncology patients, and also pregnant women, they may be given human normal immunoglobulin as post-exposure prophylaxis. And the guidelines for the dosage are the standard doses of human normal immunoglobulin. We move on to the last scenario, and this was the outbreak that occurred in 2017 and began in the city of Cape Town. You can see the timeline in the figure showing January and February 2017, and the vertical axis showing the number of cases. So a case of measles was diagnosed on 13th of January in 2017 of a young 17-year-old boy in a hostel at a boarding school in Stellenbosch. And the yellow marked dates are weekend, and exactly 9 days later, so 12 days later, another 4 cases of measles were diagnosed in the boarding house. And the health officials in this case responded incredibly promptly, and they set about and conducted a vaccination campaign at the school, and that can be seen as the green on the 3rd, 4th, and 5th of February of 2017. However, a single incubation period later, there was a whole nother spate of measles cases in the school. And this revealed the underlying vaccine hesitancy amongst the community at the school. But the health authorities had responded rapidly. No subsequent cases were diagnosed at the school, but there was a total of 22 cases in the cluster in the Western Cape. A rapid vaccination campaign was arranged, and there was a decision made to vaccinate everybody under the age of 15 in the city of Cape Town and under 5 in the entire Western Cape province. And this successfully aborted the outbreak, and an outbreak of measles was not seen, a massive outbreak was not seen in the Western Cape. So, what is the significance of this case in the boarding house? Well, measles has a very high effective reproductive number. In an unvaccinated population, there will be between 11 and 18 secondary cases. This means that in order to achieve measles prevention, the vaccination coverage in communities has to be more than 95%. And modeling has shown us that when the size of the unvaccinated population accumulates and equals the birth cohort, outbreaks are inevitable following introduction into the community. So what do we need to do then? Well, we can avert outbreaks in the case, as was seen in this case, through early detection, bring vaccination of all the contacts, and if necessary, vaccination. And that leads nicely on to the WHO Prevention, Elimination, Eradication Strategy for measles. The latest strategic framework envisages the world free of measles and rubella in 2050. The world has been doing reasonably well. If you look at this graph over here showing the number of cases of measles globally since 2018, you can see that despite a resurgence in 2019, we were doing pretty well up till 2022. However, we know that COVID-19 has disrupted routine and supplementary immunization campaigns, and in South Africa, we struggle with the legacy of low vaccination coverage in older age groups, and therefore the risk of reintroduction of measles may lead to an outbreak. The WHO has helped us by allowing us to complete a measles risk assessment tool. It uses data such as the population immunity levels, which is the vaccination coverage, the surveillance quality, the program performance, and the threat assessment to create maps that were generated by reading. It also asks questions around the prevalence of and presence of vulnerable groups, particularly migrants, communities that are resistant to vaccination, areas where vaccination routine immunization might have been affected by calamities or disasters, and where there are poor health services due to various structural and health system issues. The measles assessment will also highlight the presence of zero-dose children, and a recent review by UNICEF showed that zero-dose children accounted for 9% of all South African children in 2021, and totaled nearly 104,000 children in the country who had not received any vaccines. So the problem with zero-dose children and children who have not received any measles doses is that it takes a cluster of these unvaccinated children to allow for a focal outbreak that then may spread more broadly into the community. And therefore, identification of clusters of unvaccinated and zero-dose children is important. And so while we might look at the vaccination coverage where we want to try and achieve 95%, what's also important is to identify provinces that have the largest numbers of unvaccinated children. In South Africa, we have conducted fever and rash surveillance as we do, and this graph figure here shows the number of samples that have been tested per week, and you can see there the axis goes from 0 to 400 by epidemiological week, with 3 different colors: the blue color showing 2019 samples, the orange color showing 2022 samples, and the gray color showing 2021 samples. And what you'll notice is that the blue color, in other words 2019, seemed to have a surge during the second half of the year. What happened during this year was that there was an outbreak of rubella, and so people were sending samples to the NICD for measles rubella surveillance or fever rash surveillance, and they were being diagnosed as rubella. But you'll see in the subsequent years there was no fever, very few cases of fever rash. And when we did the testing, there were almost no cases of rubella. I think there were 3 or 4 over both of those years, and less than 20 measles cases in each of the year. So it was evident that non-pharmaceutical measures for COVID also reduced the transmission of respiratory pathogens. And this was both good and bad. It meant that during those times, we did not see any cases of measles virus, but it also led to the creation of an immunity gap for both measles and rubella. The mainstay of measles prevention and elimination is vaccination and early detection. And if we have low vaccination coverage, as is seen here for all the provinces of South Africa over the year 2020 to 2021, we sow the seeds of an outbreak in subsequent years. And it's with this that I would like to hand over to Noah to give a description of the current measles outbreak. So that's over from my side.
Thank you, Kerrigan. I think that was awesome. Maybe whilst Chenoa is preparing herself, we can just take one question and then she can then take it from there. I just wanted to check with you, following a diagnosis of measles, when can a vaccine be given?
It's a good question, Leseko. The measles elicits what we call lifelong immunity. Measles infection, natural measles infection due to wild type measles virus, elicits lifelong immunity. And so, strictly speaking, one does not necessarily require vaccination following laboratory confirmed measles. However, a number of cases of measles are not laboratory confirmed because clinicians did not take samples. And because measles has a very wide differential diagnosis, it is to the patient's advantage if measles vaccination is given. It would probably be sensible to wait 2 to 3 months post measles diagnosis or post suspected measles diagnosis before administering the vaccine. But I am not clear at the moment what the WHO guidelines are regarding this. And it is something, it is a question that has been asked actually yesterday. And so it is something that I do need to confirm. So if you have a way of communicating with your audience, I would be very happy to share the answer in a day or two's time.
Okay, that's superb. And then the last one, you on the diagnosis, you've mentioned a number of possible specimens, and probably the urine being the sort of easily available specimen. Now, if I see a case tomorrow, okay, I can collect. Which specimen is most preferred, and do I have to assess the timing, or there are standard tests that we should request anyway, or how does it work? Yeah.
If the key thing is the timing of onset of the rash. If the patient presents with a day or two after the onset of rash, a blood specimen is fine. If you have any doubt about when the rash was identified, or you want to be absolutely sure of making the diagnosis, the best strategy is to send both blood and a throat swab or urine.
Okay.
So we will test the throat swab and urine using PCR. We'll look for viral particles that have been excreted. And either is absolutely fine. It depends on what's easiest for you as a clinician to obtain.
Hey, thank you. That is quite awesome. Chenoa, welcome. I think you may take over from here, tell the audience a bit about yourself, and then, yeah, take us through. Thanks. Are you able to hear us, Chenoa? You might have she might be having a mic problem or something.
Hi, can you hear me?
Oh, yes, perfect. Thank you.
Hi, so my name is Shinoa Sanka. I'm a field epidemiology resident at the Center for Vaccines and Immunology at the NICD, and I'm currently completing my residency under the supervision and guidance of Dr. McCarthy. So I'm just going to be giving you sort of a brief update on the measles outbreak that's taken place between 2022 and 2023. So the ongoing outbreak.
Thank you. Kindly put your slides in full screen, full mode. Thank you.
So just the current outbreak status. So since October 2022, approximately 3,694 serum samples were tested for measles at the Center for Vaccines and Immunology. And of those serum samples, 560, so 15%, were confirmed positive. And of the 560, 537 of those cases were reported in the outbreak affected provinces. So the percentage testing positive has varied, and there was a peak over the December period in 2022, and a bit of a decline in early January, followed by a subsequent increase, as shown in the graph on the right. And in epidemiological week 5 up until midweek 6 in 2023, there have been 73 laboratory confirmed cases across the country. And of that 76 cases, 73 were from the outbreak affected provinces. So the outbreak began in Greater Sekhukhune district in Limpopo, and the third case was reported on the 2nd of October, after which an outbreak was declared, as that defined an outbreak. And currently the outbreak affected provinces are Limpopo, Mpumalanga, Northwest, Gauteng, and Free State. So this is a Chloroplast map that's just showing the geographical distribution of the laboratory confirmed cases by testing site and district. And the red dots indicate the size, the size of the red dots indicates the number of cases from that facility. And this is from epidemiological week 40 of 2022 to week 6 of 2023. And the laboratory, so here we have the laboratory confirmed cases reported for each province by epidemiological week. So this is from week 40 to week 6 of 2023. So that's from the 8th of October, the week ending the 8th of October of 2022 to the week ending 11th of February 2023. So the EpiCurve also indicates when an outbreak was declared in each of these provinces. So this also indicates the number of laboratory confirmed cases reported for each province and the total laboratory confirmed cases reported to date for the outbreak provinces. So the total of 537 cases reported across the 5 provinces with declared measles outbreaks. So with Free State, we are up to date have 23 confirmed cases. Gauteng has 61, Limpopo has 190, Mpumalanga has 94, and Northwest has 169 cases. So in terms of age distribution, so the age of laboratory confirmed cases across the 5 provinces ranges from 2 months to 60 years. The majority of cases, of 221 cases, which is 41% of the total, were in the 5 to 9 year age group, followed by 141 cases, so 26% in the 1 to 4 year age group, and 98, so 18% in the 10 to 14 year age group. The attack rates were highest in the 5 to 9 years age group, so 7.35 per 100,000 children. And the second highest was in the 1 to 4 year age group, so 5.76 per 100,000 children. And overall, the Northwest had the highest attack rate out of the 5 outbreak provinces of 4.04. So in terms of vaccination status, of the 537 cases, the vaccination status of 114 was known, so only 21%, and of whom that 47 were vaccinated. So 41% of those with a known status were vaccinated. And here we've got the age distribution of vaccinated persons. So this table reflects the number and proportion of laboratory confirmed measles cases that originate from hospitals as opposed to primary healthcare facilities. So cases that, while cases that are seen at hospitals may not necessarily be admitted, this proportion gives us an indication of the severity of illness as patients consulted a tertiary care facility. So admitted patients would be a subset of this number. And currently we're seeing the highest proportion of hospital reported cases in the under 1 year age group. So in terms of the notification process, so measles is a category 1 notifiable medical condition. So it has to be reported immediately. So a suspected case is reported by a healthcare worker through the NMC application. And a suspected case is defined as any person in whom a clinician suspects measles infection or any person with fever and maculopapular rash, and one of the 3 C's, so cough, coryza, or conjunctivitis. A case investigation form is then completed by the healthcare worker and a blood specimen and throat swab collected. The specimen and CIF are then sent to the NHLS lab and that is then referred to the NICD and specifically to the Center for Vaccines and Immunology, where the sample will be tested, and CVI is then responsible for communicating the results with the relevant province. So all 5 provinces with declared outbreaks have begun province-wide vaccination campaigns. The current vaccination campaigns are targeting everyone 15 years and under, so not only those who have gaps in their Road to Health card and have not completed their MCV schedule, so everybody. And during the National Measles Campaign, the measles vaccine can be co-administered with other vaccines given to children 9 months and older. So this includes HPV, TD, and Comirnaty. So in terms of just some updates on the ongoing vaccination campaign, so this is for Mpumalanga and Limpopo. So currently, a total of and 80,780 vaccines were administered up until the 14th of February 2023 in Mpumalanga, and 423,024 vaccines have been administered up until the 14th of February in Limpopo. Thank you.
Thank you very much, Chenoa. That was quite insightful. I love numbers. I wish we were having tea to even discuss further. But maybe a few questions from my side, and then we will also check on the audience. So I saw somewhere on your initial slides that there was a decline in January. Is there a reason for that, or is it because of we tested fewer people because of holidays? I don't know. What insights did we get from that?
So the decline in testing in January, so part of that could be due to the fewer specimens submitted over that time period, just because of delays over the holiday period and not as much sort of testing going on in the community. So not as many samples being submitted to the NICD as well.
Okay, superb. And I think this other question, Kerrigan, can also add, I'm not sure, because Kerrigan, in the case you presented, the case had a clear source. So someone traveling from outside the country, and maybe the case, there's an import of measles. Now, the current outbreak in the country, is there any other way for measles to just start, except I just want to understand, how does it start? I don't know, either you should or can get away. How does it start?
Essentially, you can't have a measles outbreak without a measles virus. You can't have a case of measles without a measles virus. So it has to be introduced from somewhere. And we've all seen with COVID and with how beautifully documented all the different lineages across the world have been, that disease somewhere is disease everywhere. So a lovely but tragic example is the elimination of a wild poliovirus from Africa. We'll all be familiar that last 2021 and then early 2022, wild poliovirus was again detected in Mozambique and Malawi. And essentially, when they did genotyping, they showed that the poliovirus was genetically related to the Pakistan strains that had been circulating there. And no one knows how they got there. What we suspect is that there were intermediate chains of transmission that went undocumented or undetected during COVID. And also, unlike measles, polio has a very high asymptomatic infection rate. So only 1% of cases develop acute flaccid paralysis, whereas with measles, asymptomatic infection is almost unheard of. So the point is that on our continent, we've had measles raging for a number of years. And prior to the big measles outbreaks in Central Africa over the last few years, there was a resurgence of measles in 2016, 2017 in Europe. And in fact, the 2017 outbreak that I described in the Cape Town school, in fact, was identical to a European strain. And it was, we thought, imported by a family who went skiing in Europe and had not been vaccinated. So, you say where from, it has to come from somewhere. You're absolutely right. It comes from somewhere.
Yeah, and then these are things I've just noted. Why the inland and not the coastal? Okay, I saw some cases in the coastal areas, but it's just few compared to what's going on inland, Mpumalanga, Limpopo, Gauteng.
Yeah.
Is it environmental? Yeah, thanks. Yeah.
Lovely questions. We're seeing two sort of distinct trends in the transmission of respiratory diseases across the country. The first is we see transmission from north to south, and then the second is we see from south to north. So, for example, the the measles, current measles outbreak is particularly insightful. There was an outbreak of measles in Zimbabwe towards the end of last year. It peaked in August, and there was a nationwide vaccination campaign that ended in about September, October, and it was successfully controlled. But obviously, we can tell from the way the outbreak started in Limpopo that there was some cross-border importation. Of course, diseases don't see borders. They don't have to have visas or passports. And then the other lovely, if you can call it lovely, illustration of south to north was the importation of COVID from Wuhan. The first wave of COVID was primarily focused in the Western Cape and KwaZulu-Natal, and then spread northwards. So those are the usual patterns that we see of disease.
Yes. So two last questions, and I'll also check again if there's more questions. So I'm noting, at least at my level, that suddenly there's a lot going on. You know, there's pertussis, there's cholera, there's measles. Is it COVID? Is it lockdowns? Or there's other things changing? I don't know, in the environment, or I'm not sure how your understanding of what's, or it's just coincidence. Yeah.
I think, humans and bacteria, viral pathogens have been coexisting for years, and diseases have been sweeping the world for years. I mean, I grew up reading stories about children who were orphaned through cholera outbreaks in their parents. So I think we have altered expectations in our generation because of the gift of vaccination, and also sanitation and hygiene, and for some of us improved living conditions relative to 100 years ago. And that makes our expectations of disease to be much lower. We don't expect to experience disease to the same degree that we are experiencing it now. So I think it's relative. I think this is normal.
All right. I thought that was okay. Yeah. So maybe I saw you are about to reply to Sumaya's question, and maybe you can just give advice to health workers generally. Should we be checking our immunity, or I mean, what is the advice to health workers working who are exposed, basically? Yeah.
I mean, Sumaya's question is interesting. So Sumaya's been working in a very busy casualty as an MO. She tells us she's 50. That's 1 year younger than me. And she, so Sumaya, if you've been working in casualty for many years, you've probably been exposed inadvertently to measles, and perhaps without knowing. And that will have boosted your immune response. You can, if you have any doubt, always go for a measles IgG test, and that will allow you to understand your antibody levels. But if measles vaccine is freely available, there really is no harm in getting a booster. So there is no hard and fast recommendation. Most adults, in our experience, are usually immune. And when we look at cases of measles in adults, I think the oldest case in our current series is 42 years of age, and there are 1 or 2 people who were in their 30s and then some in their 20s. During the Cape Town outbreak in the Western Cape in 2017, there was a healthcare worker who developed measles. She was in her mid-20s. So it does happen, but it's very, very uncommon.
Shenoa, let me come back to you. So are we winning? We saw the curves going up, down, up, down. Are we winning, or where are we in terms of control?
Well, with the vaccination campaigns being carried out in all 5 of the outbreak provinces, I'd like to say I'd hope that we'd eventually see some improvement in terms of the number of positive cases, but there's no guarantee. Dr. McCarthy can add to that.
No, I think she will come in because I wanted to have a follow-up. I didn't hear you talking about contact tracing. Is it not effective in the measles context versus COVID and TB? We're always tracing and trying to get people either treated or isolated or even vaccinated. Yeah.
So tracing is helpful in the early stages of a measles outbreak, or even before an outbreak, when there are sporadic measles cases and we are attempting to contain measles. However, there's a dictum to say that you cannot trace measles. One of the reasons is, as I shared, that the person with measles is infectious for 4 days before the onset of a rash. And at this stage, they might not be sufficiently symptomatic to stay at home. So a kid will probably will develop a coryzon, cough and feel achy, and be sent off to school because that's what happens, and maybe it's just a passing infection. And then when they get a rash, then the caregiver or mom will suddenly panic and, oh, you must stay at home, you've got measles. But it's too late. The measles virus has already been transmitted. The practice of ring vaccination is where all children under the age of 5 who have been exposed to the child are all provided with measles vaccine. And that is an attempt to contain the infection within that defined locale. But we often find with clusters that if people have not been sufficiently vaccinated in that community, that action has limited value in terms of containing. So public health officials should be doing contact tracing and ring vaccination now, and particularly in the provinces where the outbreak has not become established. So that's the Eastern Cape, KwaZulu-Natal, Northern Cape and Western Cape provinces. So ring vaccination is absolutely essential. However, there is a question in the chat around the decision to vaccinate children under the age of 15 in the Western Cape. And in that same question, the person asks around the number of cases in the 5 to 9 year old age group and the 10 to 15 year old age group. So the statistics presented by Chinoa are very helpful to understand what we call the immunity gap. Now, we've just come out of a period of COVID where we had very hard evidence that our vaccination coverage rates declined slightly during COVID. And that will have led to children who are now aged 1, 2, and 3 being having slightly lower vaccination coverage than in previous years. But the number of cases and the age distribution of the cases suggests to us that we're dealing with low vaccination coverage rates going back 15 years. Now, 12 to 15 years ago, we had a massive outbreak of measles with over 22,000 laboratory confirmed cases, which must have been the tip of the iceberg. There must have been hundreds of thousands of cases of measles in South Africa between 2009 and 2011. And what that outbreak did was effectively vaccinate or render immune the entire childhood population that was present at that time. So any children born after 2009 to 2011, the only way they would have become vaccinated or immune to measles is through vaccination. And our immunization coverage data and the distribution of cases suggest that that's exactly right, that we're seeing cases in the 11 to 15 year age group because of legacy low vaccination coverage. Remember, we have to have 95% vaccination coverage for measles to prevent outbreaks, and that's incredibly difficult to obtain. So why include the Western Cape? Well, the Western Cape might have slightly better vaccination coverage rates than the rest of the country, but it also didn't attain 95%. And we know that measles somewhere is measles everywhere. So it's best that the Western Cape include up to 15 years of age in their vaccination campaign. Remember, the intention of a vaccination campaign is to interrupt transmission. So if we decide we only want to vaccinate children under the age of 5 years, then and we leave the immunity gap in children between the age of 6 to 15, those 6 to 15-year-olds are all going to get measles, and they're going to transmit measles to the children under the age of 1 year who are too young to be vaccinated, or to the people who are immunocompromised and might suffer severe infection. So it's no point in vaccinating half the susceptible population. The point of a vaccination campaign is to interrupt transmission, and we need to therefore vaccinate the entire range of susceptible persons.
Yeah. So and then maximum effectiveness, is it achieved against one, or how many doses? Because I saw also people who are said to be vaccinated sort of also getting the disease. I don't know how that works.
So the success of vaccination, or the proportion of people who seroconvert following vaccination, is a function of the age at first vaccination. Maternal antibody, or IgM, lasts about 6 to 9 months, and sometimes up to a year. So an early age of vaccination leads to a lower seroconversion rate. And for this reason, it's necessary to provide 2 doses of measles vaccine in infancy. So we in South Africa administer at 6 months and 12 months, but in countries where measles is not endemic, the age of vaccination used to be 15 months until it was reduced to 12 months. So it's essential to have a second dose of measles vaccine. The other problem is that a very small proportion of people who've received 1 and sometimes 2 doses of measles vaccine may not seroconvert. And the reason for this is that measles is very temperature sensitive virus. It's a live attenuated virus. And if the vaccine is reconstituted and left at 27 degrees centigrade, it will lose 50% potency for every hour that it's at room temperature. And it might just happen that a child has been given their measles vaccine doses, but they've been given a substandard dose because the healthcare worker left it on the shelf rather than putting it in the fridge and in a cooler box. So there's small things like this that can lead to vaccine failure. And this is what the booster campaign is trying to achieve. And therefore, the recommendation is that everybody under the age of 15 receive the vaccine, even if they're fully vaccinated.
It's empowering. And I see Chibaya is saying here, so do we talk cure in the space? So is clinical improvement enough, or there's a post-test that needs to be done?
Good question, because one would want to document cure in a number of other infections. No, if a person has measles virus, it's sufficient to know the natural history of measles infection, to know that viral excretion will be eliminated or stopped by day 4 post rash onset, and that the person will have recovered. So there's no such thing as asymptomatic carriage for measles, like there is for bacterial pathogens such as strep pneumonia, and there's almost no incidence of asymptomatic or mildly symptomatic infection. Measles presents clinically and causes children to become ill, and children with measles usually recover and with lifelong immunity.
Superb. So I think the last questions from what I see in the chat, which I think we can try and close, it's around infection prevention and control. So firstly, if someone is exposed, I saw that there is a PEP, but are there tests? Do we need to do tests? And then at home, do we expect people to be on PPE, or how does do we need to put on masks and stuff? Yeah.
The measles is incredibly infectious and almost impossible to prevent transmission in a household. However, if a child is a known contact of a measles case and has not been vaccinated, it is appropriate then to isolate that child from other children who may not have been vaccinated. It's not necessary to isolate that child from adults because adults are usually immune through multiple exposure and vaccination. So the question is, would the wearing of masks help? They would, they may, but they also may not, because as I said, the virus is an airborne transmitted virus, it lingers around in the atmosphere as long as droplets are present, and it can cause measles even in with a small dose inoculum. So there are no strict guidelines around the quarantine isolation because really measles is preventable through a safe vaccine, and that really is the mainstay of measles prevention. So the key thing would be, if there are other unvaccinated children in the household, to make sure that every eligible child in a household has received the measles vaccine, and that is the way to protect one's family.
Superb. I think this one you must try and answer, because do infections open doors for other infections? I see Kefilo says in 2009 there was a chickenpox, then we had measles, and now we had monkeypox, now we had measles. Do these bugs interact and open doors for each other?
Well, one has to look at the underlying causes. Why do we have outbreaks?
Yeah.
And particularly outbreaks of vaccine preventable diseases.
Yeah.
You know, an outbreak is the last straw, really. In a functioning health system, and in an ideal world where everyone has access to good sanitation and water and early diagnosis, we shouldn't have outbreaks. So outbreaks really represent a floundering, failing health system at some level, and a floundering, failing economic system. And we are the car guards of the nation, you know, in the sense that we watch out for trouble. And when we see trouble, we call it an outbreak, and then we all go and respond. But actually, we need to be doing the preventive work of strengthening our health system, strengthening our economy in order to prevent outbreaks.
Superb. And this is from me as I close. One case of measles equivalent to an outbreak? I've had this discussion somewhere maybe 5 years ago. Does it still carry? Is it still like that?
I would like to know I'll answer that question in closing.
Okay, Chela. Is one case equal to an outbreak? One measles case?
No, so it's 3 laboratory confirmed cases in 1 district.
Oh, three. All right. Yeah, but you know, if you have one, there's probably another one. We might not have chased the other 2, but there's probably a case somewhere, you know, which we could have picked up. So I still suspect that with measles, 1 case is probably enough, but I understand. I think colleagues, don't take my word, take the 3 cases as advised. That is superb. Yeah. So maybe Shanoa, as you are here, maybe your closing remarks, the take-home message from the epidemiology side, and the key message you want our health workers to take to their facilities and in practice. Thanks.
Yeah, so just from an epidemiological standpoint, it's always good to keep up to date in terms of what's going on in your respective province and the cases that you are aware of in your district. And to keep sending specimen samples for suspected cases. So yeah, just from an epidemiological standpoint, that would be my key take-home message.
Thank you. And maybe, Kerrigan, because I saw someone talking about Tshwane, they are not getting the results. So maybe you can respond to that, and Sobar, share your take-home message as well to the clinicians who are here. Thank you. Yes,
I'll put an email address or 2 in the chat that you can reach out to try and get results from our lab. And I do apologize that I'm not sure what the problem is, and let's try and resolve it. Take home message: it's never too late to vaccinate, and encourage all your patients to vaccinate. Do our best to address questions around vaccine efficacy and side effects, and instill vaccine confidence. So it's over from me.